Okay, well, since it's 10 o'clock, we'll go ahead and get started. This is a giant room, but it's at least an intimate group, so if you feel like you have any questions you want to just like shout out, you feel more than welcome to do those things. So this is kind of a group presentation on the secondary use of electronic health records for research in emergency medicine. Just as a general introduction, I'm Andrew Taylor. I'm emergency physician at Yale University. We also have here Michael Kennedy Hall, probably well known to you all as Kennedy, who is from the University of Washington, and then Scott Levin, who is from Johns Hopkins. So I'm going to go ahead and get started. We have a fair amount to present. We don't have any real disclosures that are particular for this discussion or talk. So here are the course objectives and things that we're going to try to cover within this topic. So one, we just want to describe some of the unique kind of aspects of electronic health record research. It's definitely different than randomized controlled trial data and other things that you might encounter. And because of that, we wanted to also cover some of the limitations and issues around the quality that you're going to have with the HR data. We next wanted to kind of cover some areas in the data pipeline, and as an aspect of that, to look at data standards and why they may be beneficial. And then lastly, we're going to cover some kind of unique methods for doing data analysis in EHR research. So the structure of the talk is kind of this. I'm going to cover the data quality, kind of non-fun topic at the very beginning. And then I think Kennedy and Scott are going to be able to cover the more interesting aspects of doing the data pipelines and data analysis. We're going to have, as we transition, we're going to have just small little periods where you can ask questions, and then hopefully we'll have a little bit larger area in the back that you can ask questions as well. Okay, so hopefully everybody has an electronic health record now. I think we're all kind of into this process. It's very interesting though to look back and see that as of 2008. Their electronic health records really weren't ubiquitous across this nation, and we had the high tech out, and now there's this explosion of data that we've kind of encountered within electronic health records. I was looking back on this and thinking about what are the consequences for that for kind of research and what may have come out of that, and I think there's a few things. So one, I think electronic health records, I think we all agree, are less than ideal from a usability standpoint. And if you think about that in the context of data and research, people are not incentivized well to enter in data into the system, and we don't currently have great ways of kind of capturing that data in a way that has high fidelity. So it's something to think about kind of as we go through all of this. The other thing that kind of this rapid expansion caused was, I think, hastily constructed data infrastructures within healthcare organizations. And that, I think has a couple of things. So one, they may not have the ability to do some of the data processing that you would like to be able to do, specifically with like very high volume, high velocity data, like cardiac monitoring and stuff like that. But in addition to that, I think there was less resource investment in analysts and other people who are going to define some of your secondary outcomes, some of your operations type data that you would potentially use for research. So it's just another thing to think about kind of as you move forward. And then, through this whole process, when we had this rapid expansion, I think we weren't ready for it from a methodologic standpoint. We still, at least to my knowledge, don't have a good document or methodologic kind of standards for doing EHR research in emergency medicine. There's no kind of thing that's similar to what we have for manual chart abstraction. And I think that has also created some quality issues as well. So I'm going to transition a little bit and just talk about EHR as a data source in general. So I think one thing to realize right off the bat is I think everybody potentially sees the value in doing this. There's tons of things that you can do with EHR research if you know how to do it well. There's comparative effectiveness studies. You can do longitudinal studies and look out over time. Now there's even the ability with some of the IT systems to do kind of randomized internal studies within the EHR. There's hypothesis generating through data mining stuff. There's predictive analytics applications. And as we move kind of towards a more learning health system oriented approach, I think it becomes even more valuable. The other thing to realize about EHR data is that the volume of data may be different than you otherwise would encounter in some other areas. You know, if you do an RCT, if it's a large one, you may only encounter a couple of thousand actual either patients or visits or encounters. Within EHR research, you can encounter 400,000, a million, 2 million encounters pretty easily. And that changes things as far as how you do things, how you're going to process the data, and how you might look at it. And I think a particular good example of that is like if you're getting continuous feeds from cardiac monitors, the volume of data can quickly get into the terabytes, and it's just a different world as far as processing. The other thing to kind of realize and talk about is the velocity of the data, or kind of what you potentially see as the implementation or the kind of final product of that research. This has, I think, particular usefulness when you're thinking about predictive analytics. Do you have to, is your idea that at the end you're going to have to deliver something as a clinical decision support tool in real time? If so, the kind of way that you're going to look at the data and the way you're going to process data is going to be a lot different than if it's something where it's getting stored in a secondary EHR database that's getting like weekly feeds, and you really only need it to do some type of long-term kind of cohort follow-up or something. The other thing about EHR data is it's extremely heterogeneous. You have data that's all your demographics, your vitals, all of those things. You have your procedures, and it's coming from various different sources. But you can also think about it, you're also getting feeds in potentially from laboratory, you're getting feeds in from radiology. So there's a lot of mixed types of variables, and how to deal with those can be challenging. In the next section, we're going to talk about some of the data quality, but I think that's something you always have to consider. It's going to be always your foundation of your research, and so kind of addressing those data quality issues becomes a big component of that. And then the last thing I would kind of look at from an EHR standpoint is kind of the evolving nature of the data and the variability that you can have. It's not like you design a research form, the data collection process goes into it, and it stays like that for forever. And it doesn't take much for somebody to do a different build or change something small within the database structure, and then all of a sudden that outcome or that variable that you were using for some research has been destroyed from a quality standpoint. So it's something that kind of there needs to be some type of continuous monitoring going on for that. And then the other thing I just wanted to briefly hit on is kind of the overall view of looking at electronic health records and health systems more from a learning system approach, where you're really using research even at the local level, but then potentially at distributed kind of research environments to really inform practice quickly and have quick turnarounds. And I think that's a little bit different than we've traditionally done research. Okay, so I'm gonna go through just some, I think, what would be the main components of data quality and things that you're gonna encounter within EHR data. So these are the kind of 5 typical categories you'll see. So it's completeness, correctness, plausibility, concordance, and currency. And we're gonna go through each one of these. Completeness, I look at it, so your completeness I look at from the standpoint of it's, you have this ground truth potentially about a patient, and the database, the EHR may be somewhat reflective of that, or it may not be. A particular example would be somebody that has, they have diabetes, but they have, the first two or three times they come into an encounter, it's for some unrelated thing, and their past medical history never gets recorded, or it doesn't get entered in that they have diabetes. And so there's this idea that while there's some ground truth, that ground truth might not be reflected necessarily within the database itself, and that would be kind of an idea of completeness. It has particular implications when you're talking about it from a censoring or kind of follow-up standpoint. You can look at it for 2 ways. One, if you're seeing like when a particular process started. So when did the patient actually get diabetes? You need to know that just because there was a timestamp for an entry for a past medical history component that was done at this particular time, it may have been a long time ago before then that they actually had developed diabetes. And then we've looked at this from the context of survival within the systems. So follow up on the other end, it's entirely possible for the patient to go kind of outside of the system. You miss them, you don't realize if they're dead or alive. And so that's the kind of rightward censored component of it. From the idea about correctness, this is really, I would say, is just there's two kind of inconsistent results within the system. A good example would be somebody that's in the ED and they get intubated, and then you're looking at their disposition status and they were discharged from their emergency department. Somebody entered in incorrectly the discharge status. Or it could be that like you don't have a particular thing that says there was a death in the ED and that it's only reflected through a discharge, like the actual kind of structured field. Another example, there was a pretty prominent study that looked at how many males were admitted to OB-GYN services, just as kind of an idea that like these data entry errors occur, and sometimes it's more of a systems issue than it truly is kind of like a manual issue. Another thing you're going to encounter is an aspect of plausibility. So if you've had probably any particular lab or kind of vital sign component where you've had to have manual data entry into the system, you've probably encountered these. So people can mess things up, and instead of putting in a systolic blood pressure of 122, they put in 1,222. You can have crazy sodium values. Age can sometimes show up. Sometimes there's a default like value when people come in and they get reset to, like, if they don't know their age. Most of our like 26-year-old trauma patients come in and they're 114 initially within the system because it goes back to 1901 as the kind of date of birth that it's just preliminary set at. And so you need to know how to kind of have processing pipelines that handle those issues. And then some of the default kind of null values or missing values can be -900 and like 99 or some other particular value. Another idea is concordance. So that's where you have, it's somewhat kind of similar to correctness, but this is, I would say, more not really consistency, but where there's information that may be gleaned from one area that can inform something kind of in another particular area. I think this is tightly kind of wrapped up also in the idea about phenotypes. Another kind of using the diabetes example is a patient doesn't have in their past medical history a diabetes diagnosis, but they're on insulin, they're on metformin, their last blood sugar was 240. So there's some kind of, there's some lack of concordance in some of the data elements within the EHR. And then the last of the data quality components is currency, and this is really kind of a temporal phenomenon, and it's really about how well reflected is that the patient at a particular state and time. I think vitals would be a pretty good example. You can have a patient that comes in, they have an initial set of triage vitals that are recorded, and then they might not have vitals recorded for a period of time, and you run into issues about how do you deal with that from a processing standpoint. Do you just carry the values over into the next kind of time windows, and what to do about this? And Kennedy will talk a little bit about how to frame a lot of these issues moving forward. So the last slide I just wanted to show you was just some things that kind of anecdotally that when we've looked at data and the kind of areas and the kind of data elements that we felt like were of higher quality, medium quality, and low quality. An example would be like the reason why I kind of bridged over between high quality and medium quality areas with some of these is like demographics. Some of the demographics are going to be pretty well recorded within systems. They typically are. So gender is something that tends to be fairly well recorded. But then if you have other demographic components where you're looking at religion or other issues, the data quality might be different. So even in particular kind of areas or domains of the data elements, you may have differences in the quality of the recording of that information. So I'm going to stop there. I'm going to let the transition happen, but in the interim, if you have any questions about this part of this, the kind of first part, please feel free to ask. Okay, I'll let Kennedy come up. Yeah, go for it.
Just looking at for low quality, that you mentioned physical exam, and is that coming from a place of just because it can be documented in a structured way, in which case we don't trust it because it's just auto whatever, or is that because it can also be put in as an unstructured way and it's just kind of hard to interpret? And do you have any experience actually being able to use physical exam for anything?
Yeah, so some of this I think it's somewhat task dependent, but and I think in general we just do a bad job of documenting physical exams. There's well-known studies where if you looked back and actually looked and see whether somebody had like an S3 murmur and whether it was documented or not, because we have these structured nice data fields and macros and everything else, they just tend to get a normal exam just tends to get carried over. So there's issues around that, but then also some of it has to do, again, with the task dependency. So if you're wanting to do some type of real-time predictive analytic task, it's very unlikely that the documentation of the physical exam is occurring in real time. It's probably being entered in several hours later. So from a quality, from a use and quality standpoint, you may have problems with that. Okay, we'll transition over now.
Thanks, Andrew. So my name's Kennedy. Thanks for coming. I'm going to start with an analogy that was inspired by my grandfather who sold Herbie vacuum cleaners in Western Pennsylvania. Data pipelines need to exist, and it's maybe not the most inspirational part of data science to talk about things like cleaning. But EHR data is messy, and so my daughter Una, she's my second, she's extremely messy, but she's important to me, and I have new tools to clean up after her. So this talk is not sponsored by Dyson, but I have one of these and it's incredible. It's a game changer. I can go clean up after her. I can walk around the table, not get a cord wrapped around either of us, and keep going. So with these new tools, it becomes a lot more fun. I won't push the analogy farther. In order to start having fun with electronic health record data, we have to create a usable and scalable data pipeline. This diagram is a schematic that represented the data processing steps necessary to take data and information out of our electronic health record to eventually make predictions of interest. I'll talk more about this in a moment. To talk about an intact data pipeline was going to facilitate operations, facilitate QA and identification of sentinel events. And this talk is really about research, so prediction through modeling, either logistic regression or potentially machine learning to leverage the electronic health record. There's this concept that it needs to be end-to-end, and so the data comes out and it goes to wherever we're trying to go so that we can leverage it with as little intermediaries as possible. So what do you do when you have 400,000 records? The slide that I'm showing you is a diagram from, I think it's the most, or one of the most cited Annals of Emergency Medicine papers, Kaji et al., and it's the methodologic standards for how to do retrospective research. I'm not here to take down this to sort of like take down or speak badly about this manuscript or these methods. They describe ways that retrospective data can create bias, so you have to be aware of issues like missingness. But they make recommendations for things like standardized chart abstraction, but 10% of 400,000 records is going to leave you with too many rows to reasonably go and clean. If you're talking about variables, similarly, we can take out our electronic health records and transform data to represent thousands of columns, which are variables or features. And it's just not possible to keep up with the sort of volume and velocity of data. using standard approaches. So we have to use sort of new approaches. And just be aware of when documentation might change. So in my health system, we're changing from one EHR vendor to another. And so the data structure is going to change, and we need to be aware of bottlenecks in the pipeline. In 2013, our hospital decided to switch from manual blood pressure to automated blood pressure. And if you look at the number of systolic blood pressures per patient, starting when we switched over, the number per patient went up. The patients haven't changed. And similarly, the systolic blood pressures are 10 points higher. There's nothing different about the patient, but it's going to influence your outputs. So pipeline flow is the priority. It has to go end to end. And abstractors really can't scale. So we have to take on new and sort of like potentially counterintuitive approaches. So this slide shows a standard area under the curve, and the sort of the rightmost line would be a prediction that isn't performing necessarily well, but it's interpretable based on logistic regression. And we have to follow these rules of 10 to 15 cases per variable. We're going to, when we leverage electronic health records, have a lot more variables. And there's this other concept that regressions typically perform well with continuous data, but we're going to be transforming continuous data. So we're doing this to prioritize predictive power over interpretability. And you can take a kitchen sink approach that allows us to, again, be sort of end-to-end, and then at the very end make predictions where you just, the more variables, the better, as long as you're handling and wrangling the data responsibly. And so we can transform continuous data and discretize it. We'll talk more about that. I think it's really important to be aware of the story that's told by missing data. And so in general, missing data is sorted into ignorable and non-ignorable. You could take a semester-long course on missing data. And so I'm not going to be going into tons of specifics about it. So a missing at random variable might be like one sodium value on one patient that maybe the EDTA clotted, and so it's just not there, but it's not really influencing a story. Whereas serum lactate is one of the best examples of something that I can tell. The fact that a lactate was checked is communicating information about that patient that is a sicker patient, irrespective of the actual lactate value. But maybe, depending on your hospital system, only 10% of people get lactates or 5%. And so we need to take advantage of that information in meaningful ways. So we have to do some, we can handle missing data several different ways prior to analysis. So you can drop missings. This is called list-wise deletion, but that's always going to introduce bias. So if you had 10 patient records and 10 variables, and maybe 8 out of the 10 variables had something missing, then you're not going to be left with a lot of data. And if I sent out a survey to the room that said, hey, what do you guys think of this talk? And then I only included the 2 people that filled out the entire survey, we couldn't infer much from that. It'd be sort of like straw poll bias. The same thing is true of list-wise deletion. We can do imputation, and so there's 2 types, meaning multiple imputation. This is reasonable. Multiple imputation decreases bias, but is computationally expensive, and in a way, it's a checkpoint for your data. It requires a thorough understanding of whether or not your data is missing at random, but it's typically based on regression, or there are machine learning versions of imputation. But it's not something that is going to allow you to necessarily go faster. So next, a little bit faster would be using a missing indicator approach. So this is an approach that we've used. And so, like for that serum lactate value, you might just say, input a variable, like input a variable that's just 999, something like that, and then treat the data as categorical data. So this is using machine learning. This is also used in propensity scores. So propensity scores will collapse all of your variables into a single covariate. that is that propensity score. And as long as the missingness is reasonably balanced, your propensity score will be fine. Or you just use algorithms that are insensitive to missingness. And so one of those, which I won't go too much into, is an ensemble method, XGBoost. This is a fun area, which is just wrangling your data. So this is this concept of transforming your data from continuous to categorical. So most EHR is going to come in, most EHR data comes in several formats. So it's either nominal or categorical. And this is data that doesn't have intrinsic value, or it's ordinal, and those can be either discrete or continuous. But how do you represent these outliers? And so all I'll talk about is unsupervised ways of data wrangling. And so the sort of the two easiest, or maybe fairly intuitive, would be equal width or equal frequency. So equal width would be just representing your data over a range of values, and frequency would be just the number of instances in each bin. So here we have our sodium. An interesting, and I think still fairly intuitive way of taking, so I can take my sodium values and do k-means clustering, where you're basically looking at this data field and you're trying to minimize differences between clusters and then, or between specific values, and then maximize distances between clusters. And you just say how many clusters you want, and you specify the number. So it's sort of like, I think if we talked about sodium values, I think about like sodium less than 120 goes to the ICU, 120 to 140 is kind of normal, 140 is normal, greater than 140, and 160. So there's like 5 levels for sodium, and then here would be a representation of that. But by, so you're transforming continuous data to categorical data, but that's going to facilitate machine learning and sort of give a knowledge level representation of what the data is trying to, the story that the data is telling. Here's a particular problem that is increasingly frequent. So we've got 2 patients here. One has this medical record number. This is a bold patient. And then the other one has the bottom medical record number that starts with 134. And the first patient came into the ED. Their first heart rate was 70. Their first respiratory rate was 14. And their temperature was 37. When they left the ED, their heart rate was 120 and their temp was 41. That's a very different patient than the first patient. If you took the first row only, you miss all of that extra information. But so how do you handle this data? You have to transform it. So data flattening, there's lots of ways to do this, but we were, one of our solutions was to take this concept of just first, last, mean, min, and max values. You could also check the number, like somebody that has 20 instances of systolic blood pressure versus somebody that has 2. That's something that's going to tell a story as well. But now I've got 2 patients with 2 rows, but with 3 variables, I now have 15 variables. And so when you look in a lot of papers that have like thousands of variables, this is one of the processes that are going on. And then this data can be further transformed through discretization. Let's talk about text data. So there's lots of unstructured data in the electronic health record. There are notes. Some examples of what you can do with this. So this would be like potential for surveillance with chief complaint, which is well documented. I think an exciting area would be we all learn and teach scoring systems. And so there's the ability to automate scoring systems. So this is the PESI score. There's lots of stuff that would be fairly easy to create an automated PESI calculator, like history of cancer. You could use a past medical history, or age or sex or heart rate. But altered mental status is, if you look in the PESI score, it's the thing that has the most weight in the score. And how are you going to get altered mental status out of the electronic health record? And so you could try to do it in a structured way, or you could use a rule base, or you could use natural language processing. So we'll talk about rule bases. This is something that we do at my shop. Every DBT and PE, we use a regular expression string matching approach with multiple iterations. So this took a while to set up, but it's a robust after iteration. So all of our DVTs and PEs we review at a PE review board, and then we look and see who had a PE this day, and that's based on basically us working with the programmer for like 2 years to figure out every version of PE. So pulmonary embolism would be coded as a 1, and then the presence of no pulmonary embolism gets coded as a 0, and there's variants of this. This works great until a new radiologist gets hired, and they change the structure of the data. And so it still requires maintenance, but not as much maintenance as reading through the charts like sort of every week and trying to figure it out from ICD-9 codes where we're missing things. There are more advanced approaches that are sort of like true natural language processing that rely on semantic relationships. And I just want you to know that these are out there and increasingly prevalent. So then, lastly, I'll just talk about naming conventions. Shakespeare said, what's in a name, a rose by any other name should smell so sweet. And it's not right, or it doesn't apply here. It's not going to let us completely take advantage of our data. And so I just want to talk about some standard vocabularies and systems for handling data. So we'll talk about ICD 9 and 10, which is, I think, probably something that is more comfortable. We'll talk about the AHRQ clinical classification scheme. Just if you could walk away with what is LOINC and SNOMED, and a kind of an understanding of what that is, and then the ATC classification for handling medications. These are examples of standard vocabularies. So we'll start with, I think, the easiest. So we've got ICD-9, and then in 2015, everyone moved over to ICD-10, but these would be standard ICD-9 codes that collapse down into septicemia. The clinical classification scheme has 285 categories, but that's still better than 14,000 ICD-9 codes. The clinical classification scheme exists for ICD-10 codes, but it's in beta, and so it's not clear. You could take ICD-10, go back to ICD-9, and then collapse down to clinical classification schemes. But this lets you isolate a particular group of patients. Like if you wanted to look at boarding times, you can look at those who have psychiatric illnesses or psychiatric disorders and just look at the 5 or 10 patient types that represent a variety of ICD-9 or 10 codes. To talk about LOINC, so logical observation identifiers, names, and codes. This came out in, I think, the 90s as a solution for laboratory values initially. And it's expanded to radiology reports and then some exam findings too. Each LOINC code is unique, but it tells but the LOINC codes all tell a story based on 6 axes. So it's not just a sodium value of 120, but it talks about the components, the substance being measured, the timing, the time intervals, the specimen type that was run, and so you can get a lot of information out of LOINC. And then that hands off nicely to SNOMED, which is this systemized nomenclature that it's really like the semantic standard for interoperability. But SNOMED has a bunch of complex relationships. To just give a high-level overview, there are 9 hierarchies with these meaning concepts. And so to talk about one, the clinical finding concepts. So there's clinical finding, procedures, evaluations, specimens, bodies, pharmaceuticals, the situation with explicit context, events, and physical objects. There are over 100,000 unique concepts. And it is the closest way that we can use the electronic health record to reflect what happened or what's going on. So let's hone in on the clinical finding concepts for a moment. And in the clinical finding concepts domain, there's a diagnosis. And so prior to 2015, we were all using ICD-9. And if somebody had ataxia, they'd get coded as a 781 abnormality of gait, and that's the best you could do. But your patient may may be coming from neurology clinic and have Parkinsonian ataxia, and SNOMED can better communicate that information and communicate that information across health systems. ICD-10 is a better representation of what's going on, but it's still this one-to-many relationship. So SNOMED is sort of like the criterion standard that is, it's complex and hierarchical, but gives the best availability or the best ability to represent what's actually happening out of the electronic health record. Here's the final systematic nomenclature scheme that I want to just introduce. So it's a problem of how do you take care of and wrangle medications. So if somebody takes rivaroxaban, they may have it'd be rivaroxaban or Xarelto, or they could be taking an ACE inhibitor, but now that ACE inhibitor is batched with whatever the new drug is so that it can come back out and come off of generic, and so they're like, medications are messy. And so there's something called the ATC, Anatomic, Therapeutical, and Chemical Classification, that was put out by the WHO. It's got 14 initial domains, and then there are these 5 subdomains that describe the organ system, the therapeutic intent, and then the drug's chemical characteristics. So if we were to talk about aspirin, just sort of one of the tried and true medications, this would be an A01, AD05, which means that's a drug that you give that's an oral medication. It's also a platelet inhibitor, and it's an analgesic that has antipyretic properties. And so aspirin would map out to 3 different codes. And so you could then take aspirin, take this classification scheme, and use a 01 to sort of create a fingerprint for a patient who is on aspirin and represent that medication, similarly for all other medications. So that's it for me. I'll hand off to Dr. Levin.
I've stayed away from SNOMED just because it's so complex compared to ICD, and I'm rethinking about whether that is, whether I should be going back to SNOMED. But do you use that at your shop, SNOMED, to pull, like, if you were looking at PE, would you go to SNOMED or are you going to ICD?
So I don't currently. The complexity makes it challenging, and me personally, I don't have the resources, but our so we have an informatics department, and they do use SNOMED. I think, so if you look, we have ICD-9, ICD-10. ICD-11 is going to come out and look a lot like SNOMED. I mean, we all were sort of like laughing at the ICD-10 diagnosis, like hit by turtle from outer space, comma, second encounter. But it will get even more complex. So I think just knowing that SNOMED exists, that we start exploring it, and then just this other concept, like, so other people are going to start using, people have the ability to use SNOMED, and what happens when an insurance company starts communicating to the EHR via SNOMED to try to figure out what actually happened? Maybe we get to stop doing review of systems, but it's, yeah, I don't know if that exactly answers your question.
No, that does. And just as a follow-up real quick, are you using the HRQ to do anything?
Yeah.
Is that a lot?
That's great. And I think, I don't know if they'll talk about variable importance, but we look, so a common one is if you looked at wait times and you do a variable importance plot, you're trying to figure out what is going on, and you'll see like the psychiatric disorders come up to the top often. And so that's just like maybe one example. But yeah, that one is pretty easy to use. It's just collapsing down ICD-9 or ICD-10.
So I'm Scott Levin. I'm from Johns Hopkins, and I'm a biomedical engineer. So I'm not an emergency physician, but I've been in Hopkins EM's department for a while. I'm going to kind of complement what Andrew and Kennedy were talking about with some more how do you analyze these data. One of the first things is, of course, garbage in, garbage out. So all the stuff that they were talking about is pretty much the most important thing. And then if that is of high quality, that's when these tools can come into play. But you probably hear like a ton of hype about artificial intelligence all over the newspaper. And people use these terms. So I just wanted to go over real quickly how these terms relate. So artificial intelligence is really about programming a computer broadly to think like a human being. Then you have machine learning, which is when you don't have to explicitly program rules, you can let the machine or the computer learn those rules or the optimal set of rules. And then you have this set of methods within it called deep learning, which is really just a very specific area of doing artificial neural networks, recurrent neural networks. And that, I think, is not as germane or going to be applicable to emergency medicine for a while. So I'm just going to kind of stick with what I think is most relevant to EHR data. But when you analyze this machine learning bucket, which is probably what you're seeing in literature and things like that, there's two components of machine learning. One is supervised learning. That's prediction. So you're trying to map some sort of input like the EHR data elements to an output like the patient had a PE. And so supervised learning is applicable to all those problems. Then you have what is unsupervised learning, and that's really what they call data mining. This is when you're trying to understand how data should be organized, but you don't necessarily have an outcome of interest. And so 90% of the world of machine learning, particularly in emergency medicine, is probably supervised machine learning, but the unsupervised learning has some value too. So just to give you like a broad, high-level overview of supervised machine learning, there's a spectrum of traditional approaches to more advanced data science approaches. So the traditional approaches are things like you've heard of, like regression, linear logistic regression, naive Bayes discriminant analysis. These are things that statisticians have been using for a long time. Machine learning techniques have also been used for a long time, but it hasn't become as prevalently used because of the computing power that's now available wasn't then. So you see these traditional approaches, then you see decision tree learning, artificial neural networks, and then there's this world of advanced machine learning, which is ensemble learning and recurrent neural networks. And I'm not going to go over all these, but just to give you an idea of what's on what side of the spectrum. The one that's probably most important now is really this ensemble learning. So creating decision trees, and Kennedy mentioned a few methods of doing that. There's various methods of creating decision trees and different characteristics of data where different methods apply. But overall, it's about the computer learning how to split up data based on a tree as it relates to a particular outcome. And then doing that over and over and over again, say having 100 trees, and then having the average output of each of those trees. And that's what ensemble learning is, and there's a lot of detail that can go into that. But what's really valuable with it is it allows you to get a robust predictive model. What's bad about it is it's sometimes not as interpretable. And so just general characteristics of all these approaches from traditional to advanced. One, the traditional approaches are a lot better at explaining why, whereas the advanced machine learning approaches are going to be better for prediction. That's how they're designed. The traditional approaches, if there's linear relationships between data and outcomes, which I think is not that common in emergency, it's very nonlinear. The traditional approaches are going to be good, whereas the advanced approaches are going to be adept at like identifying interactions in data, and when certain pieces of data matter for a subgroup of patients, that it doesn't matter for another subgroup. And then you have, the traditional approaches are very well aligned with being hypothesis-driven, whereas the advanced machine learning approaches, although you can apply hypothesis to it, I think these variables should be transformed this way, and I think that they will relate to this outcome, and that's how I'm going to put them in my model, and it's very hypothesis-driven. That can be done using advanced machine learning, but one of the powers of advanced machine learning is that there can be untethered approaches. So that's good and bad. You can learn new things, learn how data relates, but at the same time you could end up with a bunch of garbage, particularly if the data isn't of high quality. So with kind of the power of machine learning, there's also a lot of potential for error. The traditional approaches are low intensity computation, and whereas the advanced machine learning approaches are high intensity. This isn't as relevant anymore with modern computers, as most all of them can handle what we would consider higher intensity computing. And then the last thing is the traditional approaches struggle a little bit more with missing data, and they're less flexible, whereas the advanced machine learning approaches can handle missing data, can be flexible, but again, if they're not applied correctly, they're prone to error. So then that was the supervised bucket. That's probably the most important. Then there's the unsupervised machine learning group, and that's methods like clustering and dimensionality reduction or principal components analysis. Really just at a high level, the point of clustering is just to identify subpopulations. You have these data, you see X and Y, here's how patients form in groups, and unsupervised methods can identify and circle those groups just like you see. Principal component analysis, like an example is shock indexed. They try to determine what transformations in data will lead to variance that relates to outcomes the best. So maybe heart rate and systolic blood pressure on their own are useful, but when you put heart rate over systolic blood pressure, the shock index, the variance related to the outcome is even better. So that variable together is better than either of those alone. And so principal components analysis is like an automated way to learn what these transformations should be. Then there's also feature selection. I'll go through this quickly because Kennedy spoke about it, but with these machine learning techniques, you end up with tons of data. You have, for example, categorical data, eye color, brown, green, blue is 2 dimensions, low dimension, whereas you get into ICD-10 codes, diagnosis, or medical history, thousands of dimensions, thousands of different things that people can have, and so that poses different challenges to these models. But generally, when you have more dimensions, more data, you're going to need more rows in your cohort to actually explore those relationships. There's a lot more potential for noise. The more data you have, the more you have to check that data and make sure it's accurate. And also, the more data you have, the less likely you're going to come up with something that's interpretable. So there's always a, objective to really reduce the dimensions or reduce the variables to only the ones that matter. And there's some approaches that can do that, particularly in supervised machine learning, such as lasso. That's what I always use, which is like a regression-based approach. If you have thousands of variables and you have an outcome, this lasso method, which is a few lines of code in R or Python, can help you determine of these 1,000 variables, it's really only these 20 that are driving or related to your outcome. So it's a pretty unbiased and method, like to me, systematic way to determine what variables you should include. And then, of course, you use your hypothesis, and between what the kind of the machine is telling you should be useful and what you just as a clinician and your hypothesis is, I think merging those things together is what will get you to the most useful outcomes. And really, the last thing is, and Andrew talked about this. You're doing this data science in the EHR. You're trying to learn new things, but what is the outcome? So is the outcome I'm trying to discover a new relationship and I want to publish that? Or is the outcome I want to deploy something in practice? I want to change behavior. For me at this point, it's always now, can I deploy something back in the EHR that changes clinicians' behavior? And I'll credit Epic. I know Epic, we have Epic at Hopkins, and I've worked with Cerner, and Cerner is very good at this as well. But there's ways to integrate these machine learning models back into the system. Taking data in real time in the ED, running it through these advanced models, and then putting it back into the EHR, hopefully in a way that is passive. It doesn't, doesn't alert or contribute to alarm fatigue, but gives simple, useful recommendations that for you all as emergency physicians just frankly don't have the time to explore a patient's chart for 2 hours like an inpatient physician will. And so can we take all that data and give it to you in a consumable form that you can look at in 30 seconds and make a decision that you may, or have a more informed decision than you otherwise would. So I think that's it. I think we can open it up to questions. And thanks for your interest and attention.
Okay. Hi, I'm Diane in Maryland. I think what you guys are doing is awesome. I think this is super, super cool. I was curious how much you have worked. You mentioned R and Python. Have you guys gotten involved? I know that there are some statistical packages in R that will integrate with electronic health records. I was wondering if that's something that you've worked with or something that you have any experience with, how effective they are, how many bugs are still being worked out. I know it's a relatively recent innovation.
I mean, so I have a lot of experience like that with that, and R and Python, which are kind of commonly used now because they're open source. If you create a logistic regression model, the output or the end of that logistic regression model is a simple equation. This variable times a coefficient plus this variable gives you a risk. And so a model like that you can't implement in these EHRs right now because it's just a calculator, essentially. But if you're going to be doing the machine learning, that currently you can't really integrate into the EHR, meaning you can't put it in the EHR. It's really this diagram on the right. You have to take the data out. We take it out onto a cloud, apply these models in an Azure or Amazon Web Service environment, and then send the data back to the EHR. But I think probably in 5 to 10 years, the EHRs will start being able to accommodate more advanced stuff. Yep.
I'm just curious, can you explain the pipeline in detail? Or just maybe some tools you're using to go from extraction to wrangling?
Yeah. So this came from this machine learning prediction of death and sepsis paper that Andrew and I wrote. So Andrew did perform the SQL queries to get the data out, and we started exploring this. So Andrew gave that slide about when he thinks the data is good, when it's not. So we looked at the missingness for all of these variables. Past medical history was maybe 6%. Lactate value is very high percent. Some things we don't have to touch. It's just good, like gender. Let's see. So meds we transformed. So we created a fingerprint for both the ED medications administered and the outpatient medications that the patient came into the door with. Past medical history was converted to using to convert the past medical history and then get the clinical classification scheme. And we did that data flattening. So we created like first, max, mean, min, last, number of systolic blood pressure, shock index. Interesting, for us, our shock index just didn't work. I created trend lines for shock, so like the multiple values, trend lines for the shock index, trend lines for systolic blood pressure, just trying to like adequately describe and then create new variables for these data. Lactate clearance, lactate trend line. There's all these different ways to explore this and then represent it by creation of new variables. And then we kept the ones that we thought, I think actually we looked at lots of different versions of models, and for us, the kitchen sink that required the least work generally performed the best on a valid, so we did our training and validation modeling. And so that's where, for me, I got to sort of peek into the black box a little bit and start feeling more comfortable. everything that was continuous we discretized and so created. I think we used 5 bins, and our justification was again just we don't know where the cut points are. It's not sodium 120, but just we sort of think along these domains like third bowl of porridge, too hot, too cold, and then so once everything was in categorical and clean, and each patient had 1 row, then it was time to do the analysis.
Yeah, and just from like a infrastructure standpoint now, I mean, I think it depends on what your intent is from maybe an institutional standpoint, and also from an individual kind of researcher standpoint. I would say there are good ways and there are good systems for doing ETL transformations out of databases to get you to kind of a data set or a database that you would want to do for or have as an institutional kind of research data set. Those features of that particular ETL process are probably going to be different than what you would want as an individual researcher. My go-to usually is a combination of SQL scripts and Python scripts, and so it's I do kind of the ETL process that way for myself. But if I was from an institutional standpoint, I would do it in a different way, put a lot more investment in it from that standpoint. I wasn't sure if that was what you were also asking about, but yeah, it's usually a combination of those types of things.
Did we answer your question? Or?
Yeah, that's definitely the goal. I would say the first time you do it is painful. But eventually you get to, like, I have now a series of scripts that pull out all of the data components that I would want. And then I have a series of scripts that process the data in particular patterns that I want. And then, to me, it is truly a pipeline to get to a kind of a final data set that we can use for a variety of different outcome predictions or other types of things.
You have flow was the priority, and
but that initial process takes a lot of time.
And then
takes years.
You have to go back if the data changes, like
unfortunately.
Yeah, for whatever reason. But so it's this, you don't have to abstract. If it's just going to be the same data structure, everything is now flowing the same way. But there's upfront investment that then gets it going again.
And the other thing I think that we didn't talk about here was institutional investments in like common data models. I know a lot of academic institutions now are becoming partners within what I would classify as like a distributed research network. So you probably have heard of like PCORNet, which is a kind of an offshoot distributed research from PCORI. And there's OMOP, which is a different kind of nonprofit organization that does common data models as well. And this is getting to kind of, again, a standardized final kind of data set that you can work with other institutions and kind of solve some of those interoperability problems that you have with collaboration across institutions. Thanks. Oh, yeah, we can talk about it. I'm just going to stop now in case, I don't know if anybody's coming in afterwards. So thank you all.